saw this really great documentary on Netflix called The Pharmacist. Have you seen that?
I have not, but I've been told about it.
Yeah, it's basically about.
Does it go over the opioid crisis or?
How did you know? It actually does. It's about this pharmacist in the U.S. who, his son has a tragic death, but basically his son got killed in a drug deal gone wrong, and then at some point this pharmacist investigates the murder, and somehow that leads him to kind of becoming very, very passionate about solving the local opioid crisis. He notices that these customers all of a sudden are buying all of these narcotics at his pharmacy, and then he traces this back to this doctor's clinic that they call a pill mill, where this doctor is basically just handing out prescriptions of narcotics for all kinds of patients who don't need it, and just basically getting paid to give prescriptions of narcotics to them. Eventually gets busted by, I think, the DEA or something like that. But and then he goes on this whole mission to take it to big pharma, who've been perpetuating the opioid crisis and things like that. But it's a very fascinating documentary on Netflix.
So his son died from like an overdose, or?
No, his son actually. So it's funny. So his son's death has nothing to do with the opioid crisis.
Okay.
It's more that I think after losing his son, he just somehow became really impassioned about trying to solve problems related to drugs in his community.
Right.
And that just eventually led to the opioid crisis.
Oh, cool. And then focuses on pharmacies, I'm guessing. Hence the name.
Pill mills, yeah.
Interesting. Well, today we have a topic that's obviously related. We're going to be covering the opioid crisis. And obviously Josh is an expert on this topic, so we thought we would.
You want to list my credentials, Alan?
Yeah, exactly. But we do have experience, obviously, reducing opioids on SeamlessMD and working with a number of prominent systems who are actively involved in preventing this crisis from continuing and reducing the crisis. So we thought it would be a good idea to cover opioids on this podcast. Josh, do you want to give maybe a summary or high level of what the opioid crisis is?
Yeah, opioids came out initially because pain management is a big thing for both chronic pain users, but also if you've had a big surgery, and pain's a big part of recovery and managing that. And then opioids, I guess, came out as this blockbuster drug as a way to tackle significant pain. But clearly, what's happened over the last couple of decades is people were we found opioids to be addictive, and then you have patients, unfortunately, where that addiction leads to overdose and deaths. And often, these medications end up on the black market and all that kind of stuff. And so there's been a big push in the past, several years to prevent unnecessary, opioid use and deaths. And I think what's interesting is that we often assume that opiate addiction starts off because people, become, are maybe chronic, pain patients, or who maybe get and then get opioids, or maybe just get opioids off of the street or in the black market. But what people don't realize is that very often it's patients who get opioids for the first time because of a surgery.
Mm-hmm.
And so in the surgery world, we've realized that, hey, like, we're contributing to the crisis in some way, and we have a part to play in trying to solve it.
And especially in the surgery world, especially with opioid-naïve patients. So these are patients that have never taken opioids before, and the first time that they're getting it is after surgery to manage their pain. I think there's a recent study that came out in JAMA, or was published in JAMA just last month, and it was for cardiac surgery, and they were finding that 1/10 of all opioid-naïve patients who are getting opioids for the first time after surgery are the ones that 90 days after surgery are still filling their prescriptions for opioids, which is obviously extending beyond 90 days. They might even become chronic users.
Yeah, it was a study done by Dr. Nimesh Desai out of Penn Medicine. It's some great work there. And I think it's important because, everyone knows that some percent of patients, everyone knows now that some percent of patients who are opioid naive, like you said, going into surgery now, kind of persistent, users. But what's often not understood is, well, what do those numbers look like for different surgical procedures?
Mhm.
Or even just getting even more granular, like what are the risk factors of certain patients that make them more likely to be persistent users? Because ultimately, what we want to do is somehow be able to kind of tailor and personalize maybe our opioid prescribing guidelines, not only based on surgery at some point, but also on the individual patient, which we're not certainly not there yet. And I think as we'll get into later in the discussion, we're still, I think as a healthcare system, globally, we're still very early on in trying to even just get basic best practice opioid prescription guidelines into place, let alone tailored personal, treatments on that note.
Yeah. And so some of the methods that we're taking as an industry to get to more of a personalized approach. I know there are opioid risk tools that are out that basically calculate the risk of a patient developing an addiction. And I think it factors in different things like age, and it factors in substance abuse history with their family and personal history, and then calculates a score for the patient. In terms of personalizing what the opioids would be for a patient, like you're saying, it would be procedure based, but then patient based. Is that what the opioid risk tool is basically doing, or are you suggesting something else as well?
Well, I mean, so the risk tools right now, all they do is they kind of spit out scores, right? So they help us kind of quantitatively understand, like based on this patient's, like say medical history, like you mentioned, what's their risk of being, let's say, a persistent user going forward, kind of thing, right? But that's all it tells you. It doesn't actually. It's often not very used in an actual way. I think one things that we think about with digital patient engagement is the idea of being like, okay, well, not only do we know their historical risk factors, but we have partners on SeamlessMD who are collecting, let's say, daily opioid consumption data when they go home. And so what we're starting to do now is actually graph out, well, what is the average what's the average number of, let's say, opioid pills the patient takes during the recovery process, and then how do we use that to better understand how much they really need. So for example, a lot of our partners are asking patients every day for the first 30 days when they go on SeamlessMD, patients get a notification saying, hey, how many narcotic pills did you take in the past 24 hours? And as we collect that data, we have our healthcare partners now looking at dashboards where they're seeing what is the actual opioid use when the patient goes home. And the idea is that, well, maybe the average patient was prescribed 30 pills after a surgery, but then the data shows the average patient is actually just taking 15. Well, now
Right.
you have data to give your team confidence that, hey, you know what, maybe we don't need to prescribe 30. Maybe we start prescribing 25 to start, and then at some point it becomes 20. And then at the same time, Seamless is collecting data from patients daily in recovery around pain scores too. So
Right.
now we can look at the data later on and say, okay, well, number one, we're prescribing less opioids over time now. And number two, oh, the pain scores actually aren't changing. The pain is
Mhm.
just as well controlled.
Mhm.
And then number three, we can ask patients, hey, like, what are you doing with, like, how many pills do you have left over? And I think what you'll find, and there's good data that came out of the University of Michigan health system, which showed that, in outpatient general surgery, for example, 72% of opioid pills that are prescribed go unused.
Wow.
And in fact, on a side note, back in 2017 in September, the state of Michigan actually did a statewide, they called it an opioid recovery drive, and patients basically gave them back 17,500 unused opioid pills. So
Wow.
there's a ton of these that just are going unused. But the
Right.
problem historically has been that healthcare providers have no data on actual consumption from patients on opioids, and so they didn't want to change their practices.
Right.
But if we can give them granular data about how many opioids patients actually take, they can safely start reducing their prescriptions and have confidence with reducing it. And I think that's good to start. But I think where we want to get to from a digital patient engagement point of view is say, okay, well, now that we know opioid consumption on average across a cardiac surgery population, a gynecology population, phase two is going to be, okay, how do we actually distill that data down further and really deliver targeted opioid prescription guidelines on a per patient basis? So the idea being that now that we have the patient reported consumption data, can we combine that with the patient's opioid risk factors using those tools you mentioned earlier, and figure out, okay, maybe there's certain types of patients who only need 5 pills, and there's others who need 10, and maybe there are others who need 25 because they have other problems going on.
Right.
So that's a sort of individual patient level personalization that we think we can get to at some point. No one's there yet, but we've at least started phase one where we're getting that granular patient reported consumption data for opioids as a starting point.
And the data is the most important thing in the beginning, because you can't make a decision without the data.
Right.
And I think it's interesting as well, Josh, you bring up University of Michigan. They're in my head, and based on the research that I've done, they are kind of leaders in this space in terms of tackling this opioid epidemic, and really taking a look at what they can study with their own patients and see how their opioid prescriptions are currently, how they're prescribing currently, what their practices are, and then what the actual consumption data is. Do you have any data in terms of the actual opioid data that University of Michigan was putting out around reducing these prescriptions?
Yeah, and so maybe to give a bit more history there, one of the unique things about the state of Michigan is they have a very strong set of quality collaboratives, especially in the surgical realm, that's supported by Blue Cross Blue Shield as an insurer. And so Blue Cross Blue Shield has often funded different quality initiatives and research initiatives so that they could better understand what are best practices to improve outcomes and lower costs, and then fund actually rolling out across the state of Michigan. So one of the things that they funded was this really great initiative called the Michigan Open Network. And what it stands for is the Opioid Prescribing Engagement Network, and it's led by some fantastic folks. Dr. Mike Engelsbe, who actually is a director of the Michigan Surgical Quality Collaborative. Dr. Jennifer Waljee, who's a plastic surgeon at U of Michigan, who's doing a lot of work with Dr. Engelslebe on the opioid initiative as well. And what they did, and I think this was back in, I want to say 2017, if I'm not mistaken, but basically they selected 6 procedures initially, and these were laparoscopic cholecystectomies or gallbladders, laparoscopic hernia repairs, thyroid surgery, prostatectomies, sinus operations, and then also gastrectomies, sleeve gastrectomies, so bariatrics. And they said, hey, we're going to take these, and they were opioid-naïve patients, and said that we're going to put them all on an opioid-sparing or opioid avoidance pathway, and advise patients to, basically use Tylenol and Advil, and then here's a little bit of opioids in case you really, really need it.
Just in case. As a rescue, yeah.
As rescue, and then they actually had them complete, patient-reported outcome surveys at the end of, I think, 30 days or something like that, or every few weeks. And the point was to see, okay, can we successfully prescribe fewer opioids than we otherwise would, and not have a change in patient satisfaction or pain? And the answer basically was yes. And then what they did then was they extended this practice to a number of other, procedures, and then collected a lot of data. And long story short is this Michigan Open initiative ended up creating these really great guidelines that you can find online at michigan-open.org. And the idea is that for I think about 18 to 20 different common surgical procedures, they show you the evidence around here's why you only need to prescribe 0 to 15 pills for a gallbladder. I'm making the numbers, but something like that. And the idea is that when they then started kind of implementing these guidelines more broadly in the state of Michigan, and they actually had about 43 hospitals that participate in using these guidelines, they actually reduced the number of opioid pills prescribed by about a third.
Right.
And they saw no change in patient satisfaction, no change in pain scores, etc. But a key thing, what they found was that you can't just prescribe a different number of opioids. It was critical that as part of this initiative, they re-engineered a lot of the patient education, right? So they had to educate patients more on opioid avoidance, the dangers of it, set clear expectations about pain management, right? Patients knowing that it's normal to have some pain, right? It's normal to kind of manage a little bit of that pain.
Tolerable amount. Yeah.
And then kind of the other neat thing that Michigan did was Blue Cross said, hey, why don't we see if reimbursing surgeons for following these best practice opioid sparing pathways will actually incentivize more surgeons to follow this, right? And so they actually Blue Cross Blue Shield in Michigan offered it's called like a modifier, basically for surgery. They basically pay the surgeons 35% more to use these opioid sparing procedures. And so in Michigan, surgeons were reimbursed about $300 to $700 more per surgery if they follow these best practices. And I think they saw a little bit of benefit there. It's unclear, I think, so far if this sort of reimbursement would be successful as a strategy statewide. But it's interesting to see that Michigan has been very forward thinking about seeing how they can, number one, establish best practice protocol, number two, tie reimbursement to that improved quality. I haven't seen anywhere else in the US or the world where they're actually tying reimbursement to following these best practice opioid pathways. That's very, very novel.
Right. I think it's also important to mention, with some of these best practice, this new education that we're giving to patients around setting expectations around a tolerable amount of pain that they'll have after surgery, that also fits in really well with what enhanced recovery after surgery is all about. Enhanced recovery after surgery is obviously one of the main goals is to reduce opioids. And in order to do that, that patient expectation setting is one of the most important factors of a successful program. In terms of the actual methods that are applied, is this something that you would see other insurers kind of jumping on the bandwagon and seeing, hey, if this is a global or at least a national epidemic, is there something that we can do to help incentivize our doctors? Do you think that would be an appropriate response from payers as well?
Yeah, I think I'm surprised some of the work done in Michigan hasn't spread more broadly, or at least to other maybe Blue Cross Blue Shield insurers in different states. I know one of the things that they've also tried in the past is actually doing a similar modifier code to the reimbursement, where for surgeons in Michigan, I think if they were doing prehabilitation, they could get additional reimbursement. I don't know if that's taken off quite as quickly either. But I do think that, ideally in my world, right, you make it truly value-based where you reimburse for the specific outcomes or metrics. But I think there's something to be said for reimbursing for best practices. So, there's fee for service on one end where you're just reimbursing them for just doing stuff like just doing a surgery. Then there's completely value-based where you're reimbursing based on metrics. But I think there's a reasonable in between where you're reimbursing for following a best practice, right? So I actually think even probably more important at this point than like specifically an opioid or a prehab reimbursement, given how widespread enhanced recovery is and how so much of enhanced recovery ties into opioid sparing and prehab. I actually think to some extent, if the payer or the government could clearly define what's the minimum number of things you'd have to do to be considered an enhanced recovery pathway, like at least the bare minimum, like probably opioid sparing, probably some other like early mobilization, whatever it is. If you can demonstrate those things, you should probably tie reimbursement to it.
Right.
Like maybe even reimburse certain organizations or physicians for actually showing that they are following an ERS pathway, because we know the data is clear on ERS. So why not, don't just pay them to do the surgery, pay them for doing the surgery well. And not just the surgery, like the whole perioperative episode.
Sure. Yeah.
Why not? Like, why is no one, I'm shocked no one has tried that as a payer, to just put a billing code for saying you've done enhanced recovery.
Right. And why do you think that is? Do you think just there's 1,000 billing codes right now and it's, too difficult for them to get everybody on board? Or
yeah. I'm actually surprised no one's tried that. And I think actually Michigan is one of the best states to do it. Like Michigan Blue Cross clearly have a mechanism for testing out a new reimbursement code for best practice, as they've done already, as we mentioned. They have so they have a clear path for how to do it. I'm actually shocked they haven't tried that. I think maybe they have, and I just don't know it. But I think that would be a great thing for them to do.
Right. I think it's also important to mention Michigan has one of the best statewide collaboratives, and I think one of the earliest ones that were formed as
Oh, I think
well.
they were the first. I think they were literally the pioneers of it. And then now
Right,
you have it in Illinois, you have it in Tennessee, you have it in Connecticut, et cetera, et cetera.
right. And so maybe that's why they have such a good relationship with their insurers, because the entire state is kind of rallied behind it, that they're able to kind of implement things a little bit faster. Could be. In terms of our technologies that we have in the hospital today, around EHRs, let's say, what's their kind of limitation for tackling this problem? I know that, with an EHR you can track opioid prescriptions, but can we go beyond that, or what's kind of the limitation there?
Yeah, and this kind of reminds me of the discussion when it comes to like smart partners doing enhanced recovery. So, the EHR is really good at telling you what I guess providers we're ordered to do. So there's thing called order sets, right? So we know, like, we document in the EHR things like, okay, the provider was supposed to mobilize the patient. They were ordered to prescribe this non opioid medication, right? But one of the missing data points in healthcare has always been the patient reported outcome, which is, did the patient actually do it? And so one of the gaps that we close with Seamless is we actually track true patient compliance, right? We ask the patient, okay, well, how many steps or laps did you walk in the hospital? Did you mobilize? How many hours were you out of your patient bed, right? How many opioids pills did you take, during recovery, right? And what you often find is that what a patient has actually done doesn't match what they were ordered to do, or sometimes, frankly, doesn't match what a provider claims had happened, right? And
Right.
so that mismatch tells you something. And so, SeamlessMD or a digital patient engagement platform of this type helps to fill in that gap. And I think more importantly, helps provide a more complete data set. So if you are thinking about building more robust analytics modules, or using machine learning to predict which, the tailored opioid pathways that the patient needs, you have to fill that patient reported gap.
Right. No, totally. And so currently that patient voice is missing, where we're missing almost one side of the equation. But with a digital patient engagement platform, we're now collecting that patient voice. We can add that data to the EHR data and get a more complete picture. In terms of how SeamlessMD is specifically reducing opioid in the health system, has that happened yet, or is it still too early for that?
Yeah, and I think the key thing that you mentioned earlier is the fact that we're number one, helping to track that opioid consumption with patients, right? So we're prompting them every day to tell us how much they're taking, and then we graph that back for the care team. So again, if they were prescribing 30 pills, and the data showing the average patient takes 15, now they can intentionally try to reduce it. So good example of that is our friends over at Atrium Health in Charlotte. They actually presented some research at the ERAS USA conference in 2019, and what they looked at was the opioid consumption data in their hepatobiliary surgery program that they collected on SeamlessMD. And basically, what they found was that the average patient used about 10% of the actual amount of
Hmm.
opioids they are prescribed. And so that's not, I mean, that's certainly not 100% of all patients who answer that data, but it's telling you that there's likely a pretty big discrepancy between how much they are being prescribed and how much they actually need.
Right.
So at the very least, that gives them pause to go, okay, maybe we can start prescribing maybe 90% of what we were prescribing before, and see if that changes patient demand for more narcotics or changes pain scores. I mean, one of the neat things that the group out of Michigan did was they looked at the correlation between number of pills prescribed after surgery and refills. And long story short, they basically found that the amount of pills you prescribe to patients for opioids was not at all predictive of
Hmm.
refills. So, like, regardless of whether you prescribe a little or a lot of opioids, 7 to 8% of patients ask for a refill of opioids. It was consistent across the board,
Right.
and that tells you something. It tells you
Right.
that pretty much patients end up using what they use to fit what you prescribe them to some extent. And so that's where we're seeing value. The other place we're seeing value with digital engagement is the education piece, right? So we're not only educating patients on like what an opioid is and non-opioid options like acetaminophen or ibuprofen, but as part of our education, we're helping them understand what are safe disposal methods for opioids? How do you return the ones you don't use so they don't end up, in the black market or end up being used by family or friends that shouldn't really be using it? You know what I mean? And so we actually go further than just the data collection and the education on opioids. We go to just the safe disposal engagement as well. And so there's multiple different ways that our partners are leveraging the platform to tackle kind of the opioid crisis across that whole perioperative episode.
Right. I imagine also like those opioid risk tools can be built into SeamlessMD as well. I'm sure some of our partners have that built into a pre-op survey, for instance, to just calculate a quick risk score.
Yeah, absolutely. And I think it's going to be, increasingly prevalent that, as we talked about, the next step in the future is let's combine the risk tool data with the consumption data and build that model out. And I think that's going to be very, very compelling.
Definitely. So basically jumping off of, what Michigan has already done, but now collecting that granular data from patients makes a more full set of data so that we can improve from there. How would the actual mechanics work for like a machine learning algorithm of opioid for a personalization effort for opioids? Do you know that, or is this something we would need to involve?
Yeah, well, given the PhD I did in machine learning and computer science at Stanford, I'm very well equipped to answer that question. But in all seriousness, I probably want to bring in some of our data science folks into a conversation, because that way they won't get mad at me later for butchering, trying to speak more intelligently about machine learning than I'm able to. But certainly the feedback I'm always getting from them, it's about making sure we have the data. The machine learning is relatively the easy part.
Right.
It's the data that typically the hard part getting. And so we're kind of in a unique position to actually help our partners capture that data and then help them build the models to predict those things.
Right. I just want to jump back for a minute. The Michigan study, I think, to me, one of the most incredible findings in there is that the patient satisfaction did not decrease whatsoever. So the median patient satisfaction was still the exact same as when they were giving opioids versus when they had far fewer opioids, when they were prescribing only like 4 pills, for instance, as a backup, just in case. The fact that satisfaction doesn't go down, but I think it was mentioned, in the study, the importance of educating the patient and going over expectations and really letting them know there will be a tolerable amount of pain after surgery. That's such a key part, I think, in this modality.
Yeah, I mean, whenever I speak with particularly like anesthesiologists and pain management specialists, one of the things that they always tell me is one of the most effective things they can do is simply set a clearer patient expectation about pain going into a procedure. It's almost like that just changes the benchmark for the patient mentally. Even just letting them know, hey, like some pain is normal, right? It will get better. Like it's not going to go away completely when you're recovering. And it's almost just resetting that mindset for the patient about what to expect, what's normal. That makes them. I mean, and psychologically it makes sense too.
Totally.
Right.
Yeah.
If someone tells me, Josh, you're going to have 2 out of 10 pain, it's okay. It will happen. You'll get through it. You'll make it. And it's better to deal with that 2 out of 10 pain on Tylenol than like potentially get addicted to opioids. If you explain it to me, I would say, okay, totally get it.
Right. And I think it's also interesting. It's in a way kind of related to prehab a little bit, where you're doing a lot more work almost on the front loading side, but to get the payoff on the back end as well. That's really cool.
Absolutely, yeah. And so, I mean, this is one of the things that's true about avoiding opioids or about ERAS or best practice in general. Like the tools are here. We know there's so much data, and like especially Michigan that does some great work with these guidelines. Like we know what the right thing to do is. It's not hard to like they figured it out. They've done all the hard work, frankly, right? But then arguably the harder work is actually getting people to change practice.
Right.
But that's a cool thing about digital engagement, Alan, is that you just like tell your clinicians, hey, we're going to enroll patients on a platform like Seamless. It's going to automate that opioid sparing education. It's going to set proper expectations that you help define internally. It's going to collect that data for you. Like in some ways, you can sort of set it and forget it, and then use that data to improve practice.
Right. And then monitor the trends over time. You can see it in dashboards, what the actual opioid trends are for the population.
Yeah. And you know what? Let's say you have some non-believers in your department. Let's say you have like, I'm making up, let's say you have 6 surgeons, right? And only half of them are bought into opioid sparing pathways. Say, okay, well, all your patients will go on Seamless, and half of them will be on the opioid sparing pathway, half of them won't. And then you can see, okay, well, maybe you can show, and this is why I predict, you can show that the pain scores, don't dramatically differ, the satisfaction don't significantly differ, and yet half your patients are using, 33% less opioids.
Right.
And then you show that data to the surgeons who weren't necessarily bought into an opioid sparing pathway. And when you show data to people, they go, okay, I get it. I believe it now.
And then that combined with, there's so much data right now showing, 1/10 of your patients will be hooked on opioids following surgery. So you combine those data sets together, and it's almost a no-brainer, the approach that you need to go.
And it's sometimes you just need to see it with your own data. And then that's one of the powerful things about the software. You can actually more quickly get that data so that they can make those proper decisions.
Right.
Otherwise, you keep persisting the dogma around opioids, and then no one gets better.
Right. Totally. Have you ever used an opioid or had a surgery that needed one?
I mean, I haven't had any major surgeries. I had my wisdom teeth taken out maybe 15 years ago, and I think I got some Tylenol 3s.
Right.
That I don't think I used, to be honest.
Yeah.
But I did have a family member in the last couple of years who went through a major surgery, and I had actually, educated her on avoiding narcotics, right? And then I remember, because I kind of just like really, really got her aware of this problem. And I remember her anesthesiologists were trying to tell her to take opioids, and she looks at them, she goes, yeah, but my pain isn't 1 out of 10. Like, why do I have to take this?
Right.
I haven't taken them yet. Why are you pushing them on me? Right.
Right.
And so this was at a big academic medical center who frankly wasn't sure even aware of these opioid sparing pathways. But it doesn't matter if you're a big brand name.
Yeah.
This is not the standard yet.
Right. And I think going back to your point about, changing practice, this is how they've been educated. This is how we've learned, well, we're going to prescribe this because that's what's in the pathway. That's what we follow. And we tell our patients, take this opioid when you have some pain. So changing practice is kind of the most important step there.
Yeah. And by the way, Alan, that might be the reason why some of these financial incentives don't necessarily work. Like sometimes you can pay someone 33% more in the surgery, but if just mentally they're not bought into the concept, they won't necessarily change. People won't just do things they don't believe in just because they're getting paid more. I think that maybe that's kind of the gap in terms of why you can't just create reimbursement codes. People magically do things. They have to fundamentally believe in the change.
Yeah. So, I mean, to that point, we'll definitely put in the show notes all of the studies that we've referenced here, all the Michigan work and the later University of Pennsylvania JAMA published study that just came out. Because I think maybe having more of these studies really does cement the realization that there is a problem, and surgeons are definitely not immune to this problem. They're contributing to it in some way.
Absolutely, that's a great idea, Alan.
Awesome. Well, I think we're running tight on time today, but I think we've covered a lot on the opioid epidemic and really how digital patient engagement can help with reducing prescription practices and at least collect the data from patients, which I think is that missing part of the equation that this technology can help support. Do you have any closing remarks on opioids or?
No, I think you summarized it well, and hopefully we can make some small impact in helping to address the opioid epidemic with our partners.
Definitely, yeah, I agree. Well, until next time, Josh, I'll see you again next week.
Yes, sounds good, Alan.
All right, have a good one. Bye.
Bye.